I'm really sort of blind myself here. So my name is Kirsten Cornell, and I studied barriers influencing and delay in treatment-seeking behavior for adults with obsessive compulsive disorder. I currently go to Baylor University in Waco, Texas, in the United States of America. And this is my research for my dissertation, which I will defend in the coming months. So I am a licensed marriage and family therapist and a doctoral candidate, all but dissertation. I have a passion for improving treatment access and creating places for community mental health advocacy. So what is OCD? OCD is the presence of obsessions, compulsions, or both. It's recurrent, persistent thoughts or urges or experienced. So these are what we call intrusive thoughts. Behaviors are things that you are driven to perform over and over and over again, and it impairs your ability to function. Why is this important? So 3% of the global population has obsessive compulsive disorder. People delay treatment on average for 17 years after experiencing symptoms, and there is a great impact for untreated OCD. So this could be, functional impairment, unemployment, relationship impairment, economic impairment, so job loss or loss of income for the family, family systems impact, and there is a great risk for comorbid depression, suicidality, and substance abuse. And there is a high rate of suicidality with obsessive compulsive disorder. So I did a quantitative cross-sectional survey through the lens of the Cone-Beam model that looks at the personal, systemic, and cultural barriers to delayed treatment-seeking behavior in adults who meet the criteria for OCD, using a demographic survey that I created and the barriers to access of care evaluation scale. My research questions. The first, is there a statistically significant difference in base scores between individuals who initiate OCD treatment within 1 year of diagnosis and those who delay treatment beyond a year or more? Are knowledge, structural stigma, and attitude barriers statistically significant predictors of whether individuals initiate OCD treatment within 1 year of diagnosis or delay treatment for a year or more? And is there a statistically significant relationship between the time from diagnosis to seeking treatment and the intensity of barriers identified by the base subscale scores? And is there a statistically significant difference in perceived barriers to OCD treatment as measured by the base between white and non-white adults diagnosed with OCD? As I said, it's a cross-sectional survey design. So my demographics questions addressed age, gender, marital status, race, ethnicity, income, religious or spiritual involvement, your living environment, the age which they were diagnosed with OCD, age when they sought treatment, and history of treatment type, if any. So the barriers to access to care evaluation scale is a 30-item survey rating the extent to which each item is an impact to a barrier accessing mental health treatment. I used moves median, logistical regression, point by serial correlation, and a Manlet EU to determine my findings. The framework, which I described earlier, is capability, opportunity, motivation, which leads to the behavior, right? So capability is recognizing that you have a mental health disorder, right? So recognizing, oh, I might have something wrong with me, right? Understanding the availability of treatment choices, possessing physical skills and stamina required for treatment participation. Opportunity is the availability of services, transportation and financial means to engage in treatment. So, for those who've been to the United States, it's really large and we have a lot of very rural population. So access can be a real factor. Presence or absence of support within social networks, access or lack of health insurance, because we don't have national health insurance in the United States. Personal attitudes for treatment, the impact of previous treatment experiences, cultural implications of accessing treatment, and the influence of your past experiences in general. And of course, that behavior is treatment seeking. So when I talk about my framework and I talk about it compared to the base, when I'm talking about capability, I'm talking about knowledge barriers. Opportunity is these structural barriers, and motivation is the stamina and attitude barriers. So my participants, I had 104 participants who fully and completely finished the entire survey. They were aged 18 to 67. The base scores are listed here, noticing that the non-white participants had the highest base scores, which indicated that they had the highest propensity of barriers. And then those who started treatment more than a year after diagnosis of OCD were also fairly high. Primarily, my participants were cisgender women. Other genders were both trans men and women, and non-binary participants. So, what are my results, right? For the first research question, I'm not going to bore you with the statistical analysis unless you're a statistics nerd like me. It basically means that there was insufficient evidence to suggest that a delay in treatment was associated with noticeably higher barriers in this particular sample. But people who waited longer to receive treatment experienced stigma and structural barriers, but did not experience attitude or knowledge barriers in my sample. People who waited longer to get help after finding out they had OCD were slightly more likely to experience difficulties related to knowledge barriers. So this is not like my own personal intelligence, right? This is knowledge about like how to navigate the system. The length of delay was not associated with shame or attitudes towards seeking help or structural barriers. And finally, despite the fact that, as I highlighted earlier, the base scores were higher for non-white participants, the difference was not statistically significant, but this could be because I had a very small sample size for non-white participants, which also talks, there is a lot of research, right, that talks about some of the reasons why people don't even participate in research who are non-white, you know, given the tragedies that have happened in the past with research. So what does this mean, right? So stigma, structure, and knowledge were contributing factors to treatment seeking. There were higher scores for non-white participants, but that was not statistically significant. So how can we create meaningful change? We can normalize stigma-related concerns and continue to screen for treatment resistance. We can offer education early in the treatment process, assisting clients in navigating cost, availability, and service limitation, incorporate telehealth solutions to reduce barriers to treatment access, and create inclusive, supportive environments that reduce resistance and promote sustained engagement in care. I have many, many more references than this, but these were the only ones listed in my presentation. Any questions?
Thank you so much, Kirsten.